Have you ever thought about what actually happens when someone is having a heart attack? For interventional cardiologists, that's not a mystery. It's their daily reality. They are there in the most emergent moments, using high-tech tools to save lives in the Cath lab. I'm Dr. J. Rutland, and today on the Health Exchange, we're talking with Dr. Priya Rao Kothapalli, interventional cardiologist, about understanding the whole picture of heart health, including procedures, but also the impact of stress, lifestyle, and more. Let's get into it. Priya, can I call you Priya?
Please call me Priya.
Okay, please call me Jamie.
Wonderful, thank you.
We know you're an interventional cardiologist, but where did you grow up? Where are you from? Like, how did you get to Texas?
My journey for interventional cardiology started when I was really young. When I was in my kindergarten graduation, I actually went up there when everybody else said, I want to be a princess, I want to be a unicorn. I said, I want to be an interventional cardiologist.
Okay.
And it comes from early exposure to the Cath lab. My dad's an interventional cardiologist.
Uh-huh.
But if you go back to our roots, we're one generation removed from a farm in India.
Uh-huh.
So we're a family of farmers from India. My dad lost his parents very early to preventable cardiac issues. And he made it his life's mission to basically help other people from having more options to prevent that kind of loss. And so I'm second generation interventional cardiology, grew up in a small town in Texas called Beaumont. I don't know if you've ever heard of it.
I have heard of Beaumont.
That's actually pretty cool because Beaumont is basically on the border of Texas and Louisiana. It's a very underserved population. My dad's office sees 3 generations of families, all with a lot of cardiac issues. And so there's a very high density of disease there. So I grew up in that community. But what really drew me to the Cath lab was when I was in my early years, was 4 or 5 years old, I'd wait up in the morning to go with my dad to the Cath lab in the summers. And what I really loved about it was, one, it was like such a warm community. You walk in there and people are just so happy to be there. It doesn't matter what time of day it is. It doesn't matter what happened the night before, but there was so much community. And I really loved that feeling of community. And so I think it kind of subconsciously programmed into my mind that Cath lab is community. And so I kind of went on my journey, found my way into medical school, went through the training, and was just drawn to the Cath lab.
Did you do med school in Texas too? Everything?
I didn't. I did a 7-year medical program in Philadelphia. So my goal was to get out of Beaumont. I was like, this is a small town. I want to see what else is out there in the world. And so I ended up in Philadelphia for a 7-year med program.
So the college med school thing?
I did. It's like they used to call us ultra nerds.
Yeah.
And so I found my way to cardiology very organically. I did this class called cardiac engineering whenever I was in undergrad. And I actually asked for special permission because I was not on an engineering pathway, and they gave it to me. And I showed up and I just fell in love with it. And I had really good mentors along the way. And you know that in medicine, it's always about who you meet along the way, what kind of experiences you have. And so I felt like it helped kind of propel me into this world of interventional.
Typically speaking, I'm going to ask you about a patient story. And most people talk about, patient stories when they're in med school or residency or fellowship, whatever. But because of your early experience, I want to hear if there's a patient story that you remember when you were 5 years old in the Cath lab with your dad.
I do. And I wish that people going into medicine could have some of these early experiences because I think this shaped a lot of how I approach medicine. And it happened when I was 5 or 6 years old. So I remember my dad had to go in for a STEMI, which is a heart attack, one night, and I wanted to go with him. And so I'm there sitting in the Cath lab. They gave me the paper angiogram charts that they used to draw on. So they didn't have medical records that were electronic back then. So I'm coloring on the paper and I look up and I see this team just working in perfect harmony. It's like a dance. They're not using words. It's just completely unspoken communication. And I was just like, how do they get things done? Because they're moving very quickly. The patient was really sick and it was an older woman. And at the end of the procedure, she just looks at them and she just says, I know you were meant to be here. Thank you so much for saving my life. And for the people in the room, it was just like, this is just what we do, the humility that they have in approaching that kind of patient. And then afterward, they all kind of gathered in the control room and they were debriefing like family. And I was just like, this is the most amazing demonstration of humanity in its best form. And so I really loved that experience, and I've really carried that forward in my own practice of medicine.
That's pretty cool. For the audience out there, can you describe sort of the structure of the heart and what a heart attack actually is?
That is a great question. And I think we don't actually give the general population a lot of information about the different types of cardiac issues, right? And the heart muscle itself is like the heart pump. So the heart pump can have heart muscle weakness. So you can have cardiomyopathy, ventricular failure. They're all kind of words for the same thing. And so those patients see a heart failure specialist. There's the electrical system, which we have the electricians of the heart, the electrophysiologists that manage heart rhythm issues. So things like atrial fibrillation, ventricular arrhythmias. A lot of people have probably heard of premature atrial or ventricular contractions, just some extra beats. And then there are the plumbers, and I put myself in the plumber category. And we basically deal with the blood flow to the heart muscle. So the blood flow is what keeps the heart muscle nourished and strong and able to do everything that it needs to do. So we're the interventional cardiologists.
One of the reasons that I like to talk to cardiologists and I become friends with cardiologists is because when you're in the intensive care unit, you truly have to understand how the heart and lung kind of work together to make certain that the body gets what it needs, right? And so you have the pump and you've got 4 chambers to the heart. So we got a picture of the heart back here. You've got the right side of your heart, your right atrium, which gives blood to the right ventricle. The right ventricle pumps blood to the lung. Take that big breath of air in. Out of the air, you snap the oxygen, you put it in the bloodstream at the capillary membrane, and then that blood flow is going to go to the left side of the heart. Left side of the heart receives it, and then that left heart pump pumps the blood first back to itself. And so where that blood vessel comes off is what she's talking about. That where that blood vessel comes off in the aorta, it's giving nutrition to the heart muscle itself. So the heart feeds itself first, and then the blood goes up to the brain and then back to the rest of the body like it's supposed to. And so when you're talking about interventional cardiology, you are intervening at that level, right? But not just at that level. I mean, you also do other things within the chamber of the heart, right? When you were training, what was the coolest thing that you were looking forward to manage as an interventional cardiologist?
I really loved the synergy of a lot of these things that we talked about. And also, I just love your description of the heart. I was just like, that is the most poetic description of the anatomy of the heart that I've ever heard. And it's perfect.
Thanks.
And I also feel like it's a metaphor for life. But going back to your question, I feel like my most exciting experience was really kind of putting it all together. And that happened for me at the very end of my training in structural interventional cardiology. So it's kind of as specialized as you can get. And I loved how you can use a picture, then use invasive hemodynamics, and then use all of these different modalities and this multidisciplinary approach to do these procedures that can change the course of people's lives. And so aortic stenosis is a perfect example of that. We had a lot of patients that were in their 80s, 90s, but functionally lived really healthy, active lives. And they didn't even realize that they've slowed down for several years until they were told, hey, you have aortic stenosis and it's in the severe category. And you ended up having, these downstream effects, but it's something that we can now treat with transcatheter therapies. And so once you treated those patients, all of a sudden they were like, wow, I thought I was just getting old, but really I just had this limiting condition where 15, 20 years ago, I maybe wouldn't have had the option of doing this.
What is aortic stenosis and how do people develop it over the years of life that they're living?
This is a great question. So I like to describe the aortic valve as the door between the heart and the rest of the body. So as you so beautifully described, the heart has to release the blood from that left ventricle into the aorta. So it's like the door that sits between the heart and the aorta. So that door, just like any door in a house, can get rusty over time. The hinges can develop calcium. You can develop thickening of the leaflets. You can have a number of degenerative changes depending on the person's anatomy and their risk factors. You can actually develop a lot of these changes over a lifetime. And so we know that patients who have aortic stenosis, it's important for us to diagnose and follow them very closely because once they hit a certain threshold, they're at increased risk for things like death.
Yeah, and the way I loved your analogy of the doorway. The way that I always explain it to patients is, listen, over the course of time, that door is going to become harder and harder to open. And if that door becomes harder and harder to open, you've got to push harder and harder against it to get that door open. That's actually your heart muscle getting a little bit bigger and getting a little bit denser and thicker. And kind of the first signs of aortic stenosis, or when you really think about it and think you need to do something about it, is when people start having signs of heart failure, which is what that is, right? That muscle getting denser and denser and thicker and losing that ability to pump as much blood forward as it should. And then people start getting more short of breath. People develop pulmonary edema. And you guys use the area of the valve, right, to really calculate when something needs to be done. Talk to me about that. And I want you to take us through step by step when you're doing a valvular replacement. I don't know the exact name of the procedure because I don't do it. I just know kind of what they do.
If you showed me your intubation tray, I would not be able to tell you any of the things on your table.
Right. But take me through what's actually happening when what we're talking about here is replacing that valve.
I think that this is a great question because a lot of people don't have that experience of coming to the cath lab and seeing what we do. But even before that, there's so much that happens behind the scenes before a patient is even considered a candidate or gets to the
Mhm.
table. And so we always want to kind of keep in mind that this is not a problem that we fix today and forget about. There's always going to be the follow up of what happens in 5 years, 10 years, 15 years. And so the serial lifetime management of valvular heart disease is super, super important. So we put our heads together with imaging cardiologists, the general cardiologist, sometimes heart failure, depending on the type of valvular pathology, and cardiac surgeons, because we want to give the patient the best option so that we have a plan moving forward. Because we do know that these bioprosthetic valves will fail at some point. And so, depending on the lifetime or lifespan of the patient that's expected, we want to make sure that we give them the right options up front. So, when I have a patient who comes in with aortic stenosis, I always want to look at their anatomy. The first step is to understand what is the morphology of the valve. We get an echo, we have a CT scan that's dedicated for cardiac structures. And so we can actually calculate and measure a lot of different metrics. The other things that we really want to know are the hemodynamics. And a lot of that we can get from echocardiogram, but if there's any question, we often do invasive hemodynamics. And so we do go in the lungs, we do a right and left heart cath simultaneously. And we get a lot of data that then we use to calculate the valve area. We can get a direct measurement of the pressure gradient across the valve. And so we get all of this information. And we also do like a pan CT because we want to know, is it safe for us to go in from the femoral artery? Or do we need to look at other sites, which would then increase risk? And, kind of having this full picture of the patient. But even more important than that, we talk to the patient. It's like, what are your symptoms? How do you live? Who do you have at home helping you? What is your lifestyle like? What are your goals? Is this even something that you would want for yourself? All of these things matter so much. And even really teasing out in very stoic patients, and I'm sure you see patients like this all the time. It's like asking people like, hey, have you noticed a change in what you can do, even compared to a 6 months or a year ago, and really teasing out the symptoms and sometimes even having them get on a treadmill if it's safe for them to see if there is something that we can induce in terms of their symptomatology. So it's very nuanced. There's a lot that goes into it. And then we all put our heads together, including the patient, and then we decide what the right thing to do is next, whether that's going to be heart surgery with a mechanical or bioprosthetic valve, depending on what kind of patient it is, whether that's going to be a transcatheter aortic valve. And then there's all the different types of transcatheter aortic valves that you can use. And then, in certain patients, they don't want anything done. For certain patients, they, don't necessarily want to go through an aggressive intervention or procedure. And so, really understanding the barriers and also understanding their wishes, I think, is a really important part of it too, because there are some patients who just don't want to treat that valvular heart disease, and that's also a pathway that's acceptable.
Yeah, cardiology, interventional cardiology has kind of gone through this crazy evolution that I love, right? Because being in the ICU guy who's accepting these patients after they have their procedures, I fully understand what the invention of being able to replace the aortic valve through your femoral artery has done to the field of medicine. Because most of these patients, under typical circumstances, you'd have to crack their chest open their chest, and actually get inside there and either fix the valve or replace the valve. That's something that's really difficult to get through, and there are lots of different complications. I don't really believe in the word complications. I'm kind of more of, as a result of doing this procedure, these things can happen because you're doing a
Yeah.
procedure. All these things can happen, and so what they said is, "Why don't we just go through the artery, put some hooks on a valve, and see if they can just hook up?" I mean, I just think that that's amazing, right? And being able to understand how positive you can affect a patient's life by doing something sort of not as invasive as you once had to is absolutely amazing. In your practice now, you're in Dallas area, right? Are you dealing with a lot of angioplasties, STEMIs, and all of that?
This is actually one of my favorite parts of interventional cardiology. You get to meet patients in this very vulnerable period of their life. Nobody expects that they're going to have a heart attack. They come to the ER, and oftentimes they're in the middle of this acute event. You get to know the person in that setting, but we move very quickly to the lab because time is muscle. So the second that they hit the door, we have 90 minutes from door to when we have a balloon open in the artery to restore blood flow. So if you think about it as the heart arteries like pipes, we basically take a very, very fine 0.01 1/4-inch wire, put it into that artery through catheters, which are plastic tubes that come from the wrist or the leg area through the femoral artery. And we take a balloon and we inflate the balloon. So it's literally just like blowing up a balloon to clear a pathway into that artery. So we want to do that within 90 minutes. So the second that they hit the door, we're all kind of moving very quickly. And my favorite part of all of this is that after the fact, you get to meet the patient and it's like you're talking to a different person and you get to know so much about them. And there's always so much depth and history and meaning. And it's just such a cool relationship to have with people.
Being in the hospital and working together, and I work with a lot of interventional cardiologists. I work with a lot of cardiologists, and I'm sure you work.
We appreciate you. You're the first person I call whenever I'm like, what do I do?
But I'm sure that there are things that you wish pulmonologists would know about the heart. What are those things?
You know, one of the bigger challenges I have, and this is not across the board, it's just in centers where they may not have exposure to advanced hemodynamics, and there's a lot more that's happening in the cardiogenic shock space. I think really kind of working synergistically to understand hemodynamics. So if we place a swan, what exactly do the numbers mean, and how do we kind of think about the physiology? And it's more for people who may not have had that exposure whenever they were in training. This is all kind of an emerging field. I think a lot of more contemporary physicians, especially in larger centers or academic practices, tend to have more exposure and education, but I think hemodynamics are super, super important in really understanding physiology to make decisions.
So you wish that the pulmonary critical care doctor would understand Swan-Ganz numbers better.
I don't even know if it's their role to understand it, but at least to have a conversation about it. I think there's some hesitancy, at least in some of the places that I've gone to work, where people are so overwhelmed. And that's the other thing. We work within an ecosystem that's super challenging. And it's like if you're managing like 200 different conditions all contained within 20 rooms, how do you have the bandwidth to focus on something that's not even really in your specialty, but we all rely on each other so heavily. So my principle is always this: if there's something that is not in your wheelhouse, like I want you to call me about it. But I know that there's always limited bandwidth, right? And even for me, it's like I might be in a STEMI. I may have been up all night doing other things. And it's just, I think, kind of juggling the resources, but really learning from each other. And for me too, it's like I would love to understand ventilators better. It's something that it never really clicked in my mind, but it's more of like that synergistic, like let's work together and really understand and help each other kind of mentality.
For you guys listening, I know we're talking kind of fast. We're going to try to slow down a little bit. But when you look at the different types of procedures that Priya's talking about, right? She mentioned Swan-Ganz catheter. So what is a Swan-Ganz catheter, right? It's a little catheter that I will put in a vein. And when I put the catheter in the vein, if you go through the intrajugular vein here, I'll go into the vein, into the right atrium of the heart, into the right ventricle of the heart, through the pulmonic valve, into the pulmonary artery, and I will measure pressures right in there. And if I can measure pressures in there, I can measure a forward pressure, I can measure a back pressure. It gives me a sense of what Priya is referring to as hemodynamics. What are the pressures being generated? Are these pressures so high that they're having an effect on the muscle's ability to pump? So when we do all of these things to you in the body, what we're trying to understand is how are these numbers affecting your physiology? And are they affecting your physiology in a negative way where we need to be doing something else, adjust the medication, thinking about adding certain valves or fixing certain aortic valves, things like that. So these are things that are done on a daily basis. Earlier, Priya was talking about an urgent catheterization for individuals who had a heart attack, which she calls STEMI, ST elevation myocardial infarction. All that stands for is the electrical signal that we see on a monitor, right, through an EKG. What she's talking about there is entering a wire through the femoral artery. So it's the artery that feeds your leg. It's a big artery. We go through that artery. We're going to track all the way back through your aorta into where the ascending aorta meets the descending aorta, past that, and try to visualize the actual vessels that are going into the muscles of the heart to see if those vessels are narrow or if those vessels are gone. And she goes in there and she opens them. And we do all of this in what's called the catheterization laboratory. So we have to use certain tools like fluoroscopy, where we're actually x-raying people and seeing if our wires are in the right place, right? So these are all things that we take advantage of. And I get it. I know we haven't really described what they are, but I want you guys to fully understand what it is. When Priya says cath lab, that's what she means. It's a special room where we take these acute emergent patients where they can be treated acutely and they can be healed acutely so that they can talk to their loved one in an hour and a half. And she does that every single day. And that's very pleasing to you.
I love doing it. And it really is that very quick, like instant gratification that I think draws a lot of us to intervention. And for me, as I've progressed in my career, it's also just deeper connection. You just get to know people in such a special way. It's like first I know what the inside of your artery feels like, and then I get to know you as a person, and then I get to know your family members. And it is just such a cool relationship to have.
So I know we're going to get into cath lab. We're going to get into vulnerable plaques, but I want to ask you a question, and this might be a difficult question. When you're under the gun and you have to treat somebody for a heart attack, at times patients die.
Oh, yeah.
Patients don't make it. The first time you had to deliver bad news as an attending to a patient, what was it? What did you say to the family? How did you deliver it?
So this was in fellowship, and I was with a mentor who has played a very significant role in my career progression. And I'm really grateful that that experience was with him because I watched how he behaved and he modeled this incredible behavior where, the patient passed on the table. It was a really sick patient who came in very unstable. We kind of used all of the tools that we have. But again, despite our best efforts, sometimes patients don't make it. And whenever we lost the patient, we paused in the room actually. So the first thing we did was we paused in the room. The team kind of had a moment together where we could just process what happened. And then we, took the gown off, took off the lead. We wear lead aprons to do our procedure to protect ourselves from radiation. We took all of that off. My mentor and I walked to the patient's family's room, and he just had such a presence. Like it was almost like an unspoken energetic presence of support, and didn't hide from it, didn't try to minimize what happened, didn't shy away from it, just kind of sat down with them and said, I'm so sorry, but we've lost your loved one, and just was so compassionate toward the family and really gave them the information that they needed to hear and sat with them for as long as they needed. And I think that is such an important part of it. It's like we're not just there to get somebody through the case, we're also there to support the people who care about them. And that was a really important experience for me. And it's something that I carried forward as well.
So something that's misunderstood, and I really didn't understand it either, is this vulnerable plaque. What's a vulnerable plaque?
Vulnerable plaque is my favorite topic in the world.
Is it really? It's your favorite topic in the world? Out of all the topics in the world, this is your favorite topic? Okay, I want to know what the hell it is, and then I want to know why it's your favorite
Well,
topic.
okay, so maybe this is actually what most physicians I wish they would know because I think it can help a lot of people. So vulnerable plaque is the concept that it's actually a proven concept that the plaques that cause heart attacks are often not the ones that cause an obstruction to the blood flow. So they're not the 80 or 90% plaques that are sitting in the arteries. It's actually the smaller plaques that are just coating the lining of the artery. So your 20%, 30%, that's often not detected by stress test or calcium score necessarily. It's usually those plaques that are sitting there that are very biologically active and for whatever reason are very responsive to inflammation in the body. So those plaques at any point in time can accelerate and rupture and then cause clot formation and then stop the blood flow to the heart muscle. So vulnerable plaque can happen really in the context of anyone. And so it's really important to remember just because an angiography report said, oh, this person has mild disease or the patient has a normal stress test, if they have risk factors, we don't necessarily know what the inside of their arteries look like.
How do you diagnose a vulnerable plaque? How do you protect somebody from dying from a vulnerable plaque?
I think there have been a lot of advances in the prevention space. And as an interventional cardiologist, my goal is to keep people out of the hospital. I'd rather not see them at 2 a.m. At some point, I hope my job becomes obsolete. In the prevention world, they're really focusing right now on understanding cardiovascular risk. We used to think it's just a lipid panel on A1C and kind of family history, and then you're good. But now we're realizing that there are a lot of other parameters that we can check, including ApoB, high sensitivity CRP, and lipoprotein little a is something that's getting a lot of attention.
What's ApoB?
ApoB is basically a molecule that tells you about your risk for atherogenesis. And so there are a number of different biomarkers that we're using now. And so it's all really in a synergistic fashion rather than using one in isolation or another, but really understanding the full profile of the patient in addition to all the traditional risk factors. And then the other thing that we can do, which I think is really cool, is, people have often talked about calcium scoring. So kind of trying to understand if a patient has some markers that are off or some family history, if they still have some hesitation, even if they meet criteria for prevention, what do we do? And so calcium score can tell us if there's calcium on the arterial wall, which would then be a surrogate as a marker for plaque. But we know that vulnerable plaque may not have calcium. And so now there's a big push in the cardiac CT space to actually use contrast cardiac CT angiography to be able to assess patients' risk. And even by CT, you can see if certain patients have high-risk features of their plaque.
It still sounds a little bit like there's an art here. Like you really got to truly understand, like this is a little bit narrow. This patient's having symptoms. We better go in there and do an angioplasty and probably keep this artery open. Because it doesn't seem like it's like, hey, that's vulnerable plaque. Let's get rid of it. It seems it's a little bit more nuanced.
It's so nuanced. And that's, I think, the most important part I've learned about medicine. It's like every single patient is so nuanced. And I don't believe in one size fits all at all. I really think it's very individualized. And say that we have a patient who has high risk plaque. That's a patient that I'm going to be really aggressive about primary prevention to prevent them from having their first event. So things like lifestyle stress management, which I think is actually severely underutilized, and certain medications that are known to lower their cardiovascular risk. And there are a bunch of things coming through the pipeline, but I think as a first line, it's really about changing the lifestyle, understanding what their life is like, modifying stress, putting them on the right medicines, and really getting them on a pathway where they feel empowered to make changes. And then, really understanding, like, if a patient had a first time event, say that I see a patient who had a heart attack, it's still not too late for prevention. So I do basically all of the same things. And in the benefit that I have in those types of patients is that I actually often will use a camera inside their arteries while I'm doing the procedure. It's intravascular imaging with IVUS or OCT. There are different modalities that we can use. And I've been surprised by how many patients have a lot of soft plaque in their arteries, even though the angiogram shows these beautiful tubes that fill very nicely, except for that one defect. If you look on the inside of the artery, you often see a lot of soft plaque that kind of uniformly coats the inside of the vessel. So you don't necessarily see it on a 2D angiogram.
This is cool. Like, I like the imaging part. So when you have an intravascular camera, and I've actually never seen this image, so like I hope that you can give me an image that we can like share.
1000%. Like I'm actually about to go give a talk on this. Like intravascular imaging is like the most important tool of intervention in 2025.
Okay, I absolutely love this. So when you're looking intravascularly, right? So you have a patient, they have chest pain. You're doing an angiogram. Let's say it's not a STEMI. Let's just say they're having chest pain, they're having angina, and you want to work it up. So you go in, you do the catheterization, you get the cath up, you've shot the arteries, and you can see that there's some narrowings in some places, whatever the case may be. Then you go in with the intravascular camera?
So I typically use it if I know I'm going to do an intervention or if I am on the fence about doing an intervention.
Okay.
If it's something that's kind of intermediate and I have discordant data, say that angiographically it looks like it's a moderate lesion. So not something that's like a slam dunk, I fix this artery or I stent. We're never really fixing it, right? We're treating this artery and it's going to improve their symptoms or improve their longevity. If I don't know that for a fact, then I'm going to pause and kind of get more information. We can do invasive physiology, which is going to tell us if there is a significant gradient across that lesion to cause a limitation to the blood flow. And then I will take it even a step further to understand, like, what does that plaque actually look like? Is it something that I can just treat with a balloon and stent, which would be a lower risk procedure? Or is this something that's calcified in a tortuous segment, that it's a longer segment that would need to be treated? And all of those things factor into my treatment algorithm because, again, it's not about time point zero. It's about what happens to a stent that I put in 15, 20 years down the line.
Now it's time for What's the Buzz, presented by BuzzRx. Every week, I answer a health-related question from one of our viewers. This week's question: Doctor, my prescription is no longer covered by my insurance plan. What are my options? You see, this happens more often than people realize, and you still have options. First, we can check if there's a clinically equivalent alternative that is covered by your plan. Second, we can look at manufacturer saving programs or copay cards, like the BuzzRx card. Many patients qualify for this. Third, if your medication is medically necessary, we can submit a prior authorization or an appeal on your behalf. And finally, we can talk about safe, lower cost options like generics or cash pay programs if needed. You see, my job as a physician is to make sure you stay on effective treatment, not leave you stuck because of all of these insurance plan rules. That's the buzz. If you have a question, email us at healthexchangepodcast@gmail.com. Thanks again to BuzzRx. Look up your medications on buzzrx.com or the app to see how much you can save. Again, I like to imagine, all right? So like I'm sitting here thinking about you putting in a camera where you've got active blood flow.
Mm-hmm.
And I'm sitting here thinking, how the hell do you see the vessel wall that's full of this blood? Like I'm sitting here thinking to myself, how can you see this thing? And I'd never seen it, right? So like when I look at your image, I'm sort of going to be like, oh, this is easy. I got it. But like what are you looking at? Like, what is it?
Imagine like ultrasound, you know, like when you do vascular access with ultrasound, it's literally the same technology, but looking from the inside of the blood vessel. And you can use like the same color Doppler type thing. It's called chromaflow if you want to see the blood flow. And we use that for dissection flaps, things that are kind of
Yeah.
different types of pathology. But in general, it's like you're basically getting an ultrasound from the inside of the artery with intravascular ultrasound or IVUS. And then OCT is super cool. It's called optical coherence tomography. And we give contrast to clear the blood pool to be able to get good quality pictures. And
Yeah.
so it's a different type of imaging, but gives you a lot of information about plaque vulnerability.
So the number one cause of death, period, worldwide is like heart disease, right? We can talk about this all day long. If you're a patient and you're on the end of this and you're listening to this, about everything that you said, what are the top 3 things you want patients to know?
I feel like there's so much medical information, but the most important thing is trusting your own gut feeling about when something is not right. Heart attacks don't always present with crushing chest pain. A lot of people have very vague symptoms. It's just something out of the ordinary for them. So it could be like a reflux or a dull aching sensation or shortness of breath or feeling tired. And women especially may have very, very different symptoms. They feel fatigue. They feel like they're not able to do what they want to do. They're winded. You know, it's not always the classic like crushing 10 out of 10 elephant sitting on my chest kind of chest pain. So my number one takeaway is really listen to your body. If something doesn't feel right, it's not right. And I think it's important for us to take it seriously because, you know, I really do believe patients know their bodies best.
In the cardiac space, what are the 3 lab values the patient should know? Like, what 3 lab values should I have in my head at all times if I present to us? What are those 3 lab values?
So 3 lab values. Can I do 4? Okay, I'm going to try to give you 3, but then it's like incomplete. And I do love
Okay, then
harmony.
give me 4. Fine. 3 is incomplete. We're doing 4 here. All right.
Just coming from ASPC 2025, fresh off the press,
Yeah.
the numbers that I think patients should really focus on for cholesterol, that's something that people ask all the time. Lipid panel wise, I think an LDL-C, super important to know your numbers.
LDL-C.
LDL-C is 1. 2 is ApoB, like we talked about.
Is it high, low? High is bad, low is fine?
Right. And
Okay.
it's also about the concordance or discordance. If your LDL is normal, but your ApoB is high, it kind of raises some alerts in our mind about what to do for that patient. So ApoB is another one. High sensitivity CRP is another one.
Mhm.
And the last one, which I think is super, super important, is lipoprotein little a.
Okay, so the 4 things are lipoprotein little a, ApoB, high sensitivity CRP, and LDL. Those are the 4 things.
Yep.
Tell me about this little a shit. What is this? What is this?
Okay, lipoprotein little a is actually like a fun topic. So it's elevated in patients who have an increase of cardiovascular risk. So things like heart attack, stroke, it's mostly genetic. So it's going to be transmitted through families. And people with elevated LP little a are much more likely to have cardiovascular events. It's not an absolute, but it is something that will like put on the alarm bells in our mind of like, okay, this is somebody I need to be more careful with monitoring, putting them on the right prevention, all of those things. And we have novel therapeutics that are coming down the pipeline, and we're still waiting on the data for that. But is there a benefit to treating lipoprotein little a directly, or is this just an indirect inflammatory marker? And
Let me ask you this question. So in individuals that, and I don't even know if you're going to know the answer. I don't even know if they've studied this yet. So let's say an individual is drinking alcohol and they're out snorting cocaine, right? And say they're 40 years old, right? Say they're individuals. Maybe we all have friends that do dumb shit. I don't do that stuff, but I got friends that do dumb shit.
we all do.
Yeah, right? Are they going to have an elevated APO little a?
LP little a, no, it's not
LP.
necessarily going to be related to their lifestyle. 90% of that is going to be related to their familial genetic kind of composition. And so it is a really good number to know because it's one of those things that's not really affected by your lifestyle so much. So yeah, it's not necessarily affected by your
And
lifestyle
all those
choices.
numbers that we mentioned, are they all lowered by statins?
So the LDL will be lowered by statin. The others don't have a therapeutic target yet. We don't know if targeting them therapeutically is going to necessarily affect cardiovascular risk, but it's kind of under study right now. So we'll hopefully have some data in the next couple of years for that.
Right now, if they're high, you're just like, oh man, that shit's high. I can't do nothing about it. Sorry.
Well, it's that plus you're able to say, hey, you're at increased risk, so maybe we should get a CT scan to see if you have high risk vulnerable plaque, and then put you on the necessary medications and the lifestyle interventions. And I do believe that knowledge is power to some extent. I think it can become a weapon if we kind of go to an extreme, but I think just having information helps us to tailor the therapy better. And I really believe medicine is individualized. It's not just a one size fits all.
Yeah, one of the things I found fascinating is, again, I'm an immunology nerd. And so when I look at immunology and I look at cells communicating with one another, not just, white blood cells, but epithelial cells, which also line the coronary arteries, like that communication is so important. And when you look at heart attacks and strokes, a lot of it is cell communication. It's the inflammatory system. It's these cells talking to one another, these molecules binding to their receptors, causing these things to happen. And individuals and physicians have to pay attention to that because each individual is different, right? They respond to different things and sorts. I mean, that's just how I think about that.
Okay, I think we were meant to be friends because you just said all my favorite things in like one sentence. I do believe that the endothelium is its own organ system. I do believe inflammation affects every single part of our being. And I'm super into like the energetics of the body, like our emotional, mental, soul level kind of, shifts, what we experience in life. I really believe that all of it affects the inflammatory pathways in our body, the way that we express our genetics, all of the different things.
Yeah. How does sort of your mental health or your stress play a role in cardiac disease?
It is a huge, huge driver, and I think it's been under-recognized for a long time, and it's so easy for us in the office to be like, "Hey, work on your stress," but it's like, how do you work on your stress? And I'm not working on my stress, like, how do we do that, right?
Right. I want to switch gears for a second and I want to ask you some fun questions. I want to lighten this up a little bit and we're going to call this rapid fire heartbeats. All right. So I want to ask you quick questions, quick answers. I want to have a little fun with this. All right.
All right,
And if you have a question for me, I'm happy to answer it too. One heart myth you want to bust.
that heart disease does not happen in women.
Most rewarding part of being an interventional cardiologist.
It's just cool patients, like, you get to talk to them after, and they're just kinda like a totally different human being.
What's the most challenging part of your job?
It's the dealing with loss, and honestly, even more so recently is what I've learned is the ecosystem, sometimes dealing with a very challenging ecosystem in which you have very little control.
Hardest decision you had to make as a doctor.
Ooh, picking a specialty.
That's the hardest decision you've ever had to make.
Yeah,
A specialty.
I loved a lot of things. I mean, was it easy for you to be a pulmonologist? You're like, "Yes, the lungs are mine."
Yeah, I knew I didn't. Well, the reason I picked pulmonary critical care was because I didn't want to let go of anything, and I
Yeah.
felt like with pulmonary critical care, I still have to know a little bit of almost everything. I got to know a little nephrology. I got to know a little cardiology. I got to know a little dermatology. I got to know immunology. So like, I thought it was pretty easy.
That's actually why you guys are some of my favorite doctors. It's like, if I don't know, chances are you will absolutely know.
We'll have something to contribute. I wouldn't say that we would know. I wouldn't say that. What's one lifestyle change that makes the biggest difference for patients?
Stress, in my opinion. I think
Stress management.
stress management and finding what works for you and not falling into the trap of like, oh, it worked for them, so it's going to work for me. I think really individualizing and learning to tune into the body
So,
and managing stress.
so if you have a patient, they come to the hospital, whatever, you meet them, they have a heart attack, you're seeing them now outpatient wise, you've talked to them, and they have mentioned to you that they have some outside stressors in their life, something that they really can't control, right? Their kid is sick or their mom is dying, something like that. What is your piece of advice to help them deal with that aspect of their life? What do you tell them? Is there a psychologist you refer them to? Do you teach them how to breathe? Like, what do you teach them?
I think it's different for everyone. And so my belief is like even just having presence, like just literally sitting with them and letting them share with you what's going on, like that's a huge exchange of trust already. And I think the things that I've done that have seemed to help is I kind of share, with them options. So what's out there. And I really believe that people are intuitively drawn to whatever they need as long as they know what exists and they have credible sources for it. So things like mindfulness practices and really understanding like, hey, in order for me to help another person, I have to prioritize my own well-being and really tuning into what does that feel like in my body whenever things don't feel good versus I feel like I'm in harmony so I can show up as my best version of myself. So it's really reframing a lot of that.
What's the best advice you've ever received as a doctor?
Trust the intuition. It's everything.
What's the worst wellness trend you've seen patients try?
Ooh, it's like jumping on these extreme diets. It's like people think like the quick fix is to just, starve yourself or eat like only one thing forever. And it's just kind of like, again, it's one size does not fit all. It may work for some people, but the data does not support doing certain extreme things.
Yeah, my thing is like eat organic. When human beings ate organic, when everybody ate organic, we lived till we were like 30. Like, get out of here. Like, medicine has done so much more than that. Anyway, what's your favorite tool or technology in the cath lab?
Intravascular imaging. It's a game changer. It makes procedure safer. We get detailed information about risk stratification. Stents stay open for longer. People have less future events.
See, if I'd have paid attention in cardiology, I would have done cardiology because that intravascular imaging, like I love imaging. I think Like, when I was growing up, cardiologists never looked at any image unless it was a Cath image. That was about it.
Like, what is this 2D picture?
Yeah, yeah,
Unimpressed.
exactly. Yeah, I'm not impressed with this. What's one lesson you learned early in your career that stuck with you?
The most important part is community. Whether that's the people you work with, your patients, your friends, whoever supports you, community is everything.
So one piece of hard advice you'd give to everybody listening.
Learn to really tune into your body and trust yourself and really understand that it's all connected. It's not just one organ or one problem that's happening. I think that, if we really tune into ourselves and we really trust our body, we will learn that everything is connected. And, we talk a lot about inflammation and stress and all these other things. And I really think it comes down to living in a way that feels good.
It's the favorite song you blast when you want to de-stress. And I'm going to even be more specific. You've just lost a patient on the cath lab table. And, there's an 81-year-old that had a STEMI. What song are you listening to on your way home?
I'm probably listening to a playlist that I made when I was in yoga teacher training in Costa Rica last year. And it's all this music that connects you with like these different energetic frequencies. And for me, it's almost like it helps my body recalibrate. But sometimes like I'll have a day where I just had a bad day and I'm like listening to Bleeding Love on repeat. It was like my high school breakup song.
Bleeding Love?
And now it's like how I get through a rough day.
Wait, so how many high school breakups did you have to actually have a song for it? It seems like a lot of high school breakups to have a particular song for it.
That is so funny.
Listen, I just asked
There were a couple.
Yeah. All right.
But I've always been also like a very like open person. So like I love deeper connection with people. And so I do tend to take it pretty hard whenever something goes wrong in the cath lab or in the work environment if there's conflict. And so I know a lot of us are like that. We're these really highly empathetic, very attuned people. So I do feel like music brings a shift.
Mm-hmm. We're talking about de-stress. We're talking about applying music, and you talked a little bit about breathing. One of the critical lessons I learned growing up was that people can actually have stress-induced cardiomyopathies, right? Yeah. Takotsubo, and you can have this like mental stress-induced ischemia that I was recently reading about. Tell me about that mental health and induced ischemia, or even mental health and Takotsubo.
It's a very well-known correlation that people who've gone through extreme experiences or big periods of emotional stress can have cardiac manifestations. So you mentioned Takotsubo cardiomyopathy. It's basically whenever the heart muscle becomes weak and the apex, so the very end of the heart, it balloons out. And there are different variants of it, but it can happen to pretty much anyone. Women tend to present more with stress-induced cardiomyopathy, also spontaneous coronary artery dissection. I wish people would think about SCAD more because it's a diagnosis where it's basically like people come in with a heart attack type presentation. The angiogram, whenever we rush them to the cath lab, may not look like a classic heart attack, but usually there are subtle findings that would kind of raise those flags of, hey, this may be SCAD. Really important to identify those patients because they need different lifestyle interventions than other people would, but it's very underdiagnosed.
Tell everybody what a dissection is. So when she says SCAD, you said spontaneous coronary
artery dissection.
What's a dissection?
A dissection is basically so the artery has 3 layers, and so whenever those arterial wall layers unravel, it's basically like tissue paper coming apart. Whenever that happens, it's called a dissection, where the artery wall integrity is compromised.
And the reason it's dangerous is because the blood flow will go into that wall instead of going to the heart where it needs to go.
Exactly.
Right?
And it can be an area where clot forms and then causes complete obstruction of the artery. There are a lot of things that can happen. And those scenarios are ones where we don't necessarily stent the patients, believe it or not. And it's because whenever we put instruments into that artery, we have the potential of just unraveling that artery further. The only situation in which we would actually treat that with stents is if somebody is in shock, like they're unstable and it's because the blood flow is compromised, in which case we'd probably put in a temporary heart pump and then open up that vessel the best that we can, versus sometimes even get surgery involved.
Yeah. So what you guys have to imagine here is if you just think about the inside of the body and you have these endothelial cells lining these vessels, right? If it rips, just think about it for a second. If it rips, there's a couple of things that actually end up happening, right? So when the endothelium rips or when it's injured, it's going to release inflammatory mediators that are going to recruit over different types of cells. The first things that kind of come over to the area, which aren't really cells because they don't have a nucleus, are called platelets. So platelets come to the area and they try to repair and clog up that little hole. So what she's saying is when platelets are activated and you try to clog up that hole, that means that the coagulation cascade gets activated as well. So these are the proteins that are involved in leading to blood clotting. And so you have platelets activated, you have blood clotting behind those platelets. And so it can create a acute obstruction. And that's what she was explaining. That's the problem that can develop. And so what she's saying is when you have this spontaneous coronary artery dissection and all of that can take place, putting a stent there may not actually help you. That patient may need an emergent surgery. I think that's what you're telling me.
You know,
correct?
it's possible, and again, it's so nuanced, right? It's like every patient's gonna be different, and we really try not to stent them. We try not to repeat image them because even injecting contrast, so when we take those pictures, we have a little plastic tube that engages the origin of that artery from the aorta, and then we actually mechanically inject like a couple cc's of contrast, so contrast medium into the artery. And there's a condition known as hydraulic dissection where we can actually just extend that dissection even just by injecting
Because of
contrast.
the pressure.
So we really try not to take them back for repeat imaging unless something clinically changes. And those are patients who really benefit from follow-up CT scans so we can see if the endothelium has healed, if there's anything else that needs to be done, those kinds of things.
And mental stress can lead to
Oh
that
my gosh.
spontaneous dissection.
I will tell you, for some reason, like, I don't know if you have this experience, but patients come in sets of threes. And in my first year of clinical practice, I had three back to back to back SCAD patients, all women in their 40s to 50s, all taking care of so many other people. And they didn't feel like they have time to take care of themselves and dealing with a very heavy mental stress burden, very little support. The general phenotype that I see is people who have a lot of stress in their lives. And it's not necessarily, people don't want to come into the hospital with this condition, and a lot of them actually wait until it gets so unbearable. So this is a process that's probably been going on for days. But really, it's just stress is a big, big risk factor.
So the people who are most at risk, you said younger women, because you said
Younger
40-50-year-old
women.
women, post-myocardial infarction patients?
Yeah, post-myocardial infarction, patients with underlying psychiatric illness. This is a population that I think we all need to do a better job with in the medical community. Patients that have mental health issues, especially things like bipolar disorder, schizophrenia, that spectrum of illness, they have an increased risk of cardiometabolic disease, and we tend to underdiagnose and undertreat them as well.
I read this book called, it wasn't Wildhood. I can't remember. It was written by Barbara Horowitz, who was like an evolutionary biologist, but she used to be a cardiologist and a psychiatrist.
Wait, a
And
cardiologist and a
she's a
psychiatrist?
cardiologist and a
It's so
psychiatrist.
funny
And
that you mentioned that. One of my friends, we talk about this all the time. He's like, basically, I feel like I'm a cardio psychiatrist because a lot of what we do is counsel people on this kind of stuff.
so she went into the field of evolutionary biology and started studying animals. And it's really interesting because a lot of physiology that we come to understand as humans, so like Takotsubo cardiomyopathy, which I don't know, I can't remember, we started talking about it, I think, in the 70s or 80s or something like that. But it was actually written about in monkeys 30 years before. And it's just really interesting hearing her talk about it
Mhm.
because as she's studying animals, there are certain things that she thinks about. Like if you look at the giraffe, right, with the long neck and the amount of pressure that has to be generated to pump blood all the way up there, it's ridiculous. It's like 300 millimeters of mercury. And the brain can withstand that amount of pressure without having like a hemorrhagic stroke, right? And so it's just really interesting. It's like she kind of went into all of this talking about it. And I just thought that her talking about all these things and being a psychiatrist was all like really, really, really interesting.
I need to find that book.
Yeah, there. Oh my God, what was the name of the first one? Ubiquity is the first book. That's the book I had to read. Yeah, yeah. When you're talking to your patients and you have them in your office and you know that they have some degree of anxiety or some degree of stress, are there a team of people that you have that support your practice that you can refer these patients to? I know you're a yoga instructor. Do you say, "Hey, I see you're stressed. Come to my class." Like, I mean, like, what do you, how do you approach them? What do you do?
It's tough. A lot of systems don't have any of those things integrated into the model. I think healthcare does a really, really good job of like the physical aspects of medicine, but the things that we can't see, it's harder for us to have the resources to treat them, right? And I tend to tell people like, hey, these are the things that I've tried personally that have worked for me. I don't know that they will work for you, but these are good starting points. But I don't really have a ton of resources to give them. And that's my hope in kind of having some of these conversations. It's about how do you find credible sources for these other adjuncts that could be incredibly valuable for your healing process? Because I don't think it's just going to come down to, see problem, fix problem mechanically, treat problem with medicine. I think those are incredibly important, but I think there's another layer to that as well.
Yeah, stress is hard. It's one of those things where I'm just like, you talk to your patients, and I'm always like, hey, listen, like, you got to think about yourself. Like, you don't have the physiological capacity to deal with this outside thing.
Yeah.
Like, you really got to focus on like your health. And it's so hard to tell people that, because if you tell them that, they're like, you don't understand. Like, you don't get it. I really have to deal with this. Right. And if the person's like your spouse, it can be even worse. It's like, you
Yeah.
don't get it. You're not, sad enough. And it's like, it's really, really difficult to deal with stress. And it's really, really difficult to give people advice on dealing with stress.
And I think physicians struggle with it, right? We know that we have some of the highest suicide rates among all different professions. We have very little support when it comes to that. And I think a lot of it is if you don't sleep enough and you don't have the resources you need to take care of yourself. And a lot of people also have financial strains and other strains that are just practical realities of life. How do you help people recognize that, you can find that safety and stillness within, even when everything in the world seems to kind of be up in the air?
Exactly. And there are things that you can deal with, right? That can help you through stress, like lifestyle modifications, lifestyle factors. You already said sleep, exercise, the diet. Like, there are so many things that can help you that people may not even look at. I mean, exercise is extremely beneficial.
Like literally just going out for a walk.
Right? Like,
Yeah.
it's extremely beneficial. When I'm talking to patients, I'm like, listen, go outside and walk, go outside and run on I don't care what you do, just move and get that heart rate up, because it's almost like it's clearing out your system. You're able to get rid of that negative energy that you're thinking
It's like
about.
the energy body kind of recalibrates.
You mentioned a lot about energy and calibration and all that. Tell me more about that. I want to hear what's going on inside your mind when you are thinking about that.
We don't talk about energy a lot in medicine, and I became really interested in it in the cath lab. So I realized that as we're doing cases, like I don't have to speak, like the team around me just knows and we kind of harmonize. And we're kind of in this like beautiful dance. And it feels like everybody's energies are kind of moving together. And then I don't know if you've had this experience, but sometimes when I walk into the ER, whenever I get called for a STEMI, like all the hairs on the back of my neck will stand up. And I just get a feeling that this patient's just going to be really sick, even if there's nothing physically objective data wise on the screen. And inevitably that's what happens. And so it's like really tuning into that sense. And I started questioning, like, what is that? We don't really talk about it. And I don't really have a framework for it, but we all kind of talk about like clinical intuition. Like it's kind of a vague concept. And as I went through yoga teacher training, I started learning about the energy body. It's about this electromagnetic field that we emit from every single heartbeat that we have. And it's a huge field. And as we are sitting here, our energy fields collide. And there are some ways of quantifying and measuring, but we don't necessarily apply that to physical medicine, but it doesn't mean that it's not there, right? So I've become really interested in that space. Talked to a lot of people. I read a lot of books. Anatomy of the Spirit is a really interesting book by Caroline Myss, and it has a really cool framework because she actually worked with a neurosurgeon as a medical intuitive and describes a lot of these energy principles that we all kind of have access to, but don't necessarily understand or trust.
Being in cardiology, and I don't know if it's the same, but I know that me being a Black physician, being underrepresented can affect me. But women in cardiology are also underrepresented, right?
Oh my gosh, yeah, no, I'm curious about your experience too, but women in structural interventional cardiology make up less than 1%. So it is a very, very small percentage of the field, and I feel like the culture is shifting slowly, but just not quickly enough to my liking. And I really think it comes down to value in our patients, how we take care of patients, the diversity of patients that we see, the trust that we build, the resources that we put toward research, education, all the different things. It's many, many layers. But I'm kind of curious about your experience, if you don't mind.
Well, I want to tell this story first. There is this structural interventional cardiologist at University of Iowa, Dr. Dimitroulis. She's passed away now, but I remember I was a second year resident. My buddy Zaid was on service with me. He's one of my best friends in residency. And this patient's creatinine kept going up right after she had had her cath and all that. And now we're like 3 or 4 days into the admission. We've been diuresing her. And there was this one day where I was like, you know what? I think she's dry. And I'm going to tell Dimitroulis. And I'm just like sticking to it. And she was notoriously like hard on everybody, like super hard on people. Super. And this day I was just like, I'm not backing down. Like, I'm going after it. And I gave her all the evidence why she was dry. And she was like, but seriously, like, it's not that. And I'm like, she's dry. She's like, no, it's not. This is like for the 15 people. She's like, no, it's not. I was like, she's dry. She's like, no, she's dry. No, she's dry. And I just felt like then the reason this story sticks out of my mind is because I'm thinking about females in the field of cardiology and how you have to be that way to just kind of like, same thing being Black guy. You have to force yourself in the room and like, this is what it is like, it's not that I'm going to represent myself and you're going like, this is how it is. And I just felt like like you had like this strong, like female person that I really looked up to. And then you also had this like black, like resident. And I'm like, the only one. And like we're just like going back and forth, right? And it was like, and I think that's why we kept going back and forth is
Yeah.
because of that. Like I was like, she's dry. He's like, no. I
Yeah.
was like, she's dry. She's dry. And then finally at the end of it, Dimitrilis was like, give her 500 cc's. I was like, fine. But like, no, I mean, my experience is like, I was always told it's never because you're black, because my grandparents didn't want me to be limited by that thought, right? Even though they fully understood that it very well easily probably was.
Mhm.
And so I operated that way throughout many instances when racism was clearly obvious in the room, whether I was a college student, med student, resident, fellow, all of that. You're kind of too accustomed to experiencing. If you cause any ruckus or disagree with anybody, it's, angry black man or whatever,
Yeah.
right? So you have to sort of skirt your way through that, right? If I had a reason for doing something, I better have 10 reasons, even though Peter over here can have one,
Yeah.
right? So I mean, and it's just the way it is, and I'm not complaining. It doesn't bother me at all. These are things that I think about and scenarios that I think about, but you have to remain, I don't know, calmer. Like you have to be able to absorb all of these things, and I'm sure being a woman.
It's so relatable. And I just think what a powerful stance and position to be able to show people and also represent right in this way with what you've built. And I really take pride in that too. It's just, I think, kind of, though it's scary sometimes to put yourself out there in the medical community, I feel like that's the only way that change happens. And something that I really wish I had as I went through my training was the ability to meet people who I could relate to, like people who were other women in interventional cardiology who didn't take on that tough exterior, because that just was never me. I'm never going to be the person to fight my way to the front of the table. But I kind of took on the role of going on social media during COVID, trying to find people. And eventually I became that person for people. And now I know that people that I've mentored are becoming those people. And so what you're doing is like on an exponential level, which is a really cool thing.
Thanks. I mean, I don't really think I'm doing anything. I just kind of do
But you
one day at
are.
a time. Like, doesn't
But
even.
you are, and I think it's just like you never know who watches your episodes or sees you speak or sees you share, and it creates that ripple effect into the world.
Yeah, I don't disagree with that aspect of it. When you think about heart disease, are there gender differences between males and females?
There are so many gender differences between the different genders, and that goes down to patients, but it also goes down to operators. I think there are differences in how we approach problems. Very like female kind of approach, which I've talked to other surgeons and proceduralists about this, and I don't want to generalize, but from my experience, we tend to kind of pause before we react. It's a very split second pause, but it's kind of like you can see the pause and then the action, whereas I think some of my male colleagues will do and then react. And when I was in I don't want to generalize because
Yeah.
it's never going to be
Yeah.
a bucket statement, but when I was in training, people would actually kind of be like, why does she do that? Like, it's like it's a problem. And then as I got into the world and started doing stuff on my own, people were like, I'm glad that you pause and you tell us what you're thinking. And it's a gender difference. It's just sometimes there is a mistrust of something that's unknown. So whenever you're kind of like charting new territory, and I've been thankful that there are people who've come ahead of me who've paved the way, but I just think it's still very much uncharted territory. And even down to like the devices that we use, I was sitting in this engineering meeting for a new heart valve technology. And they were like, okay, demo this deployment system for us. And I was like, this hurts my thumb because it's so bulky that it literally does not fit in my size 5 hands.
Yeah.
And they were like, we've never had somebody like you come to this thing. And I was like, what do you mean like you? And they're like, we've never had a woman demo our product
Oh, wow.
because there are so few of us.
Right.
So it makes sense. Like people just don't know what they don't know.
But you're proud of that.
I, I'm proud of being able to show up and contribute in that way. I am.
Yeah. And your dad's probably super proud of you. What do you think are the top 3 takeaways from today?
I just think it's so cool that people across disciplines of medicine think about health and well-being in a global sense. I think that's much needed. And so hearing you talk about that is like very encouraging and uplifting for me. The second takeaway for the audience is that if there's something going on and something doesn't feel right in your body, always trust it and always find a person who can help you with it. And, I don't think medical gaslighting, the term, I don't think people necessarily mean to do that, but we're in a system where there's so many demands and pressures that sometimes it's hard for people to wrap their head around, what's going on with the patient. You never know when you catch somebody, and it shouldn't be that way, but a lot of those things are outside of our control. But I just believe that if somebody knows there's something not quite right with them, I always tell them to trust it.
We always end the show with a positive pulse. Something where you went through something with a patient. It was a very positive experience, positive outcome. You have one for us?
I do. So just a couple weeks ago, I took care of a farmer who came in with a heart attack, and farmers are notorious for coming in at the last minute. They want to wait until it becomes unbearable, which I recommend not doing that. So this patient comes in and he basically comes to the ER and his heart stops. So we're doing CPR. We get him intubated emergently. I had to call the pulmonologist. I was like, please help me.
Yeah.
And so we get him to the cath lab, open the artery, get him upstairs. He's fine. The whole thing stabilizes. And the next day I'm like walking up to his room to check on him in the ICU, and I hear him on the phone and he's talking to his buddy, and he's like, hey man, guess what? He's like, I died last night and I'm alive now. And I was just like, like when people can find that kind of joy in such a chaotic and traumatizing experience, like I was just like, wow, like this guy's attitude, this is just amazing.
I'm alive, bitch.
I'm here.
Yeah.
And I love that. It's like even, patients who are, come in with cardiac arrest, young patients, and, they're intubated. We do the emergent procedure, use temporary mechanical support. They're extubated, and the next day it's such an awkward but great conversation because you're just like, oh, so thanks. I'm just like, thank you.
Yeah. Where can we find you, Priya?
So I'm on all the social medias. I'm also starting a podcast as well, and I really need you on there because you have so much insight. It's called Open Heart. And so social media, Open Heart, any of those areas.
And what's your name on social media?
So my Instagram handle is dr.Kothapalli, my last name.
Perfect. Listen, you guys, we talked about interventional cardiology. We talked about cardiac prevention, illness. We talked about all kinds of things. There's lots of things we didn't talk about. If you guys have any questions, go ahead and ask us the question. I'm sure we can answer. Thank you for watching and listening. We're on Instagram at the Health Exchange Podcast. We're on Apple, Spotify, iHeart, YouTube. Get us wherever you get your podcasts. We're on every Thursday morning at 6 a.m. Pacific, 9 a.m. Eastern. We'll see you next time, and definitely next Thursday. Take care.